the ICU. So we'll start out with kind of the general overview. We'll go through some definitions, a little bit of pathophysiology, talk about some cases, management, a very brief discussion of mechanical ventilation. This is not going to be the lecture you get on mechanical ventilation. That is a whole lecture into and of itself. And then we'll take time for questions. And depending on how efficiently we get through this, then I actually have some kind of review questions to go through, which might be more suitable for the second and third year residents, although interns, if you have answers, feel free. So starting out, of course, respiratory failure is the loss of the ability to adequately ventilate or provide oxygen to the blood and systemic organs. And so keep in mind, there are multiple different components to the respiratory system, right? So in the brain, the respiratory center activates the phrenic nerves, which makes your diaphragm, intercostal muscles, scalenes move, and then your lungs expand. You have airways, alveoli, parenchyma, and the myoneural junction. There could be problems in every part of this pathway. And so when you're thinking through, why does this person have respiratory failure and how do I need to manage it? You need to keep in mind that there can be an error at any part of this. I think we tend to assume that there must be some either parenchymal or alveolar issue most of the time, but it can be at any point along the path. So a case that you may see during your residency here, 68 kilogram, 42-year-old female admitted after a drug overdose, found down with vomit in her airway. She was intubated and had mechanical ventilation, all started in the emergency department and then admitted to the ICU for your excellent care. Blood gas prior to intubation, 738, PaCO2 36, PaO2 of 57. And so when that patient comes to you, you have to think about, well, what is the cause of their respiratory failure? So that's when we get to the different types of respiratory failure. And it's been divided into 4 different types, although really you only have to worry about type 1 and type 2. So type 1, hypoxemic, and this is defined as PaO2 less than 50 on room air. And then you may recall the physiologic causes listed. What I want you to do is to concentrate on this nice little cartoon that demonstrates again shunt and dead space. So let's go through this. So in the middle, you have an alveolus that has normal gas exchange. So there's no blockage in the airway, nothing filling the alveolus, and normal blood flow, right? So then you have a VQ ratio of 0.8. Over to the left, where you have perfusion without ventilation, meaning there's something blocking the airway or the alveolus is full of something, but blood flow is normal. That's called shunt. And then to the right, ventilation without perfusion. So air is going all the way down the airways and into the alveolus, but for whatever reason, there is no blood flow around here. That's called dead space. It's important to keep in mind what those 3 things are, because as you work through the differential, these things, ooh, I am echoing. These things will be important. All right, let's see. Hey, Legacy IM, can you mute? I think we might be getting an echo from you. Or Dr. Lopez. I'm looking at the people who aren't muted. Okay, thanks everyone. Okay, so the physiologic causes listed here, there are only a few that you're ever going to see. So the venous admixture, very rare that that's actually an issue that we're ever going to diagnose. So let's look at these causes. Now, when you're trying to sort these out, obviously low inspired PO2 is really not going to be an issue that we have to worry about, right? Because that's occurring at high altitude. So what you usually do to sort out what might be going on is you look at the A to A gradient, right? And the A to A gradient is the PA, big A, O2, which is FiO2. So PaO2, so pressure in atmosphere minus the pressure of water times the FiO2, right? So, and that's usually 150. So here in Portland at sea level, that number is 150. Oops. And then from that, so the big PaO2 in Portland, 150, you're gonna, and then subtract the PaCO2 divided by respiratory quotient, right? And then that gives you the PaO2, and you subtract the blood gas measured PaO2, and then you have your A to A gradient. Once you have that, then you can look through here and you can figure out what's going on. So if people are hypoventilating, their A to A gradient is normal, and if you give them oxygen, it corrects 100%. If there's a diffusion disorder, the A to A gradient is going to be elevated. It will correct with oxygen. EQ mismatch, again, it's elevated, will correct with oxygen. And if they're shunting, it's going to be elevated, but shunt is not correctable with 100% oxygen. And then these are the examples of the things that can occur here. So when people are hypoventilating, what you want to think about is the fact when we go back up to the respiratory system, when you are awake, your drive to breathe is the reticular activating system. When you're asleep, it's the medulla oblongata. So you have to think about, as far as your differential goes, what could be going wrong in the brain with hypoventilation? And then you move down and you think about, well, what could be going wrong in the spinal cord, and then the peripheral nerves, and then the muscles, and the myoneural junction. And that can help explain why people are hypoventilating, because it isn't always drugs, right? Although certainly that can be part of it. So that's where we have this differential over here to the right. Diffusion disorder is very commonly interstitial lung diseases. BQ mismatch, of course, that is extraordinarily common in our patients. That's where we have PE, COPD, chronic bronchitis. And then shunt, we're always thinking about pneumonia, pulmonary edema, ARDS. Occasionally we'll have cardiac etiologies of shunt, or we'll even have pulmonary AV shunts. So type 2, hypercapnic. This is defined as a PaCO2 that's over 50. And it's either increased CO2 production or decreased CO2 elimination. It is extraordinarily rare that we have to worry about increased CO2 production, because that's going to occur in exercise, overfeeding, thyrotoxicosis, increased catabolism, metabolic acidosis, and fever. Where I've seen this manifested are in patients who are chronically critically ill and stuck on ventilators, and we have a more difficult time ventilating them. It can be because they've been overfed, or they're in this catabolic state because of their chronic critical illness. And so we know that that's the problem. There isn't really a way to correct it. But that is rarely what you're going to have to work up acutely. Most of the time, it's decreased CO2 elimination. And so I'm going to take you through the alveolar gas equation, and you might be thinking, really, why do I have to know this? This was on step 2 of my board exam. I thought I would never have to think about it again. The reason why we want to go through it is because conceptualizing this is going to help decrease the amount of memorization that you have to do. And memorizing always sucks. So think about PaCO2 is equal to a constant times the production of CO2, so it's VCO2, divided by alveolar ventilation, right? So how much do you produce and how much do you eliminate? And that creates how much PaCO2 you have dissolved in your blood that we can measure. So what we really want to know is what leads to alveolar ventilation because that's how you eliminate CO2, right? So alveolar ventilation is equal to tidal volume, so how much breath you take in and exhale, minus the dead space, right? So dead space are the bronchi, the areas where you aren't doing gas exchange, right? Because gas exchange is only occurring at the alveolus, times frequency. So how fast you breathe and how much you breathe, right? That is what alveolar ventilation is. And it's important to keep in mind that if you have increased CO2 production, usually your body is going to get acidemic. That's going to tell your medulla, hey, you need to breathe faster. And so you actually will increase the frequency and hence alveolar ventilation. So it's really uncommon for increased CO2 production to be a cause of acute hypercapnia, unless there's some reason why the patient can't increase their minute ventilation appropriately, which that could be because they're paralyzed or sedated, or they had a big stroke or something else. So when you're thinking about alveolar ventilation, right? So we want to try to figure out how do people get hypercapnic, right? So we think about alveolar ventilation. So what reduces tidal volume? Could somebody put in the chat box things that reduce tidal volume? See if I can actually monitor the chat. Oh, this is participatory, kids. I know you're spacing out, I don't know, playing Candy Crush or something on your phone. What sorts of things will reduce your tidal volume? Mechanical body habitus, restriction, obesity, hypoventilation, good. Kyphosis, oh, one of my favorites, kyphoscoliosis. When you see those people whose chest is so squished together because they have such a severe kyphoscoliosis, yes, absolutely, it leads to restrictive lung disease. Splinting, people who have rib fracture, very common after we give them CPR or if they've had any sort of trauma contusion, atelectasis. All right. So I'll give you some of my answers. Thanks for playing along. So of course, pulmonary fibrosis, you have fibrotic lungs, that's going to reduce your tidal volume. COPD reduces effective tidal volume because you have all of this lung that can't participate in ventilation. Asthma, neuromuscular diseases, right? So thinking about motor neuron disease, just fatigue, people tiring out will reduce their tidal volume. Muscular dystrophy, Guillain-Barré, myasthenia gravis, Lambert-Eaton, spinal cord lesions, ALS, and then certain toxins. All of these things will make it so you can't expand your lungs as much because your muscles can't actually do their job to create that negative pressure in the thorax. Fatigue, chest wall diseases, which, you know, splinting, so flailed chest. People who have pectus excavatum with other lung disease and stiff chest wall syndrome. There is I have never actually seen it myself, but there have been multiple descriptions in the literature. When you give people high dose fentanyl for a prolonged period of time, it can actually make their chest wall stiffen. And so you actually can't get much lung excursion. What helps is to actually stop the fentanyl and start a different opiate if necessary. All right. Kyphoscoliosis, and then of course, obesity, hypoventilation. So y'all named quite a few of those. All right, so we know tidal volume is one of those things, right? So thinking about, when you're thinking about your differential, if you're hypoventilating, tidal volume is one issue. Now, what increases dead space? Can you give me some things that increase pulmonary dead space? Some of them could be similar to the things that decrease tidal volume. Yes, emphysema, very good. Think about things that happen only in the intensive care unit that could increase dead space. Pulmonary embolism, yep, that can definitely increase dead space. Although it's really uncommon. So a point that I'll make is it's uncommon to actually see hypercapnia and pulmonary embolism, mostly because there are other factors that lead to increasing your respiratory frequency, like the hypoxemia, but it definitely does cause dead space. The endotracheal tube, well, actually, so the endotracheal tube itself is a small amount of dead space, but the long tubing actually can be a great deal of dead space. ARDS, yeah, so thinking about things that we do to people on the ventilator who have ARDS. All right, I have to guess what I'm thinking game is great when you have to guess what I'm thinking. So, of course, pulmonary embolism, COPD and reactive airway disease. And if you have a hard time thinking about conceptualizing how you have more dead space with COPD, remember that in emphysema, you actually have destruction of the capillaries surrounding the alveolus. You also have airflow obstruction that can lead to hyperinflation. So it can actually kind of compress those vessels. And then you can have reduced lung compliance at high lung volumes. And so that causes poor blood flow around the alveolus because the alveolus is kind of over distended. And that's how you have more dead space. Paralysis. Well, you know, so if you weren't mechanically ventilated, yes. All right, pulmonary vasculitis also increases dead space, same mechanism, right? You have destruction of the capillaries, particularly capillaritis, where you have aerated units. Alveolar overdistension. So it's not uncommon for us to try more and more to try to manage hypoxemia. Occasionally, we can actually overdistend lung units, and that can actually cause more dead space. So that's why sometimes you'll see us working with a respiratory therapy, working on the flow volume loops, or we'll do serial blood gases to try to figure out what the optimal PEEP is. And then, of course, obesity, hypoventilation. Okay, so now what sorts of things can decrease the frequency or respiratory rate? So what can cause hypercapnia by decreased frequency or respiratory rate? Drugs, yeah, you guys are good. This is what you've seen a lot of, right? So people who come in with an opiate overdose and have lost their drive to breathe. Keep in mind, it actually does take a fair amount of opiates to lose your drive to breathe, or opiates in combination with other drugs. Of course, there are exceptions. So new synthetic fentanyls like carbafentanil is extraordinarily potent, like 10,000 times more potent than the fentanyl we give. And so small amounts of that can actually cause complete cessation of breathing. And CVA, so stroke, yep. So brainstem lesions, drugs, meds, and then Undine's curse is where you stop breathing when you fall asleep. Great. Okay. So then there are type 3 and type 4 respiratory failure. Honestly, this is not something that I have ever talked about in any conferences or ever talk about professionally. People put these together. Really, these are kind of mixed types of disorders. So type 3 is called post-operative hypoxemia. It's usually related to atelectasis, and then type 4 related to shock. But again, I think this is frequently more dead space and sometimes hypoxemia. So think about really the either hypoxemia or hypercapnia and understand that, of course, these disorders can all be mixed. All right. So separate case, we'll get back to case number 1, but case number 2, you walk into a patient's room, blood pressure is normal, heart rate is 105, oxygen saturation is 78%. You've got a blood gas that's 742, PCO2 38, PaO2 is 45, and they're 78% on Remer. So what are your first steps? The ABCs, excellent. Examine patient and chest x-ray. Yeah, those are good thoughts. Well, so always focus on supporting the patient's respiratory failure. So think about their airway first, right? So just like you said, ABCs. And what you want to do, because an oxygen saturation of 78% is quite low, is get oxygen on. And there are lots of different ways we can apply oxygen. So we're going to go through that a little bit. And then also airway control, and then thinking about circulation. One thing that we're not going to talk about during this discussion, but should be part of any ventilator management discussion, is the fact that it is way more important to learn how to bag mask ventilate than it is to learn how to endotracheally intubate. So always think about how can you apply oxygen, and do you need to apply ventilation? And then of course, reverse obvious causes. So thinking about the tools we have available. So 3 tools: nasal cannula, venturi mask, and non-rebreather help with oxygenation. And then high flow nasal cannula and both non-invasive and invasive ventilators help with both ventilation and oxygenation. And then after you've done this emergent management, just kind of getting the ABCs done, then you start thinking about what's the differential and what should we do next. And then you create your plan according to the diagnosis. So let's spend a little bit of time on the oxygen delivery systems. So nasal cannula. Everybody's seen one of these. This little diagram below shows the proper way to put a nasal cannula on a mannequin. So the little prongs should be facing downward. They should both be inside the nose, and it should be behind the ears. There are some different securement devices available. It is the most common and cheapest device we have. You can get low flow rates, so if you don't need much oxygen, it actually works very well. You can get anywhere from 1 to 12 liters per minute, which gives you a concentration of about 24 to 60% FiO2. Although that FiO2 is really determined by the patient's respiration and how much they breathe through their nose versus through their mouth. The rule of thumb with respect to nasal cannula is 20% FiO2 is, these are slides from a different friend. So what I say is for every 1 liter of oxygen, you get about 4% increase FiO2, which is why when we extubate people, we want their FiO2 to probably be around 50%, because we could still get by with oxygenating them via nasal cannula once we took them off the invasive mechanical ventilation. The cons, so how are people usually wearing their nasal cannula? It's usually on their cheek, in their eye, on their forehead. So it moves very easily, and then it doesn't work very well on people who breathe through their mouth or have significant obstruction in their nose. You'll see simple face masks. They have a larger reservoir for higher FiO2, so that's right here in the face. People actually can put up with this a little bit better than the nasal cannula because the airflow is going around more areas instead of just shooting in their nose. It's really hard to tell how much FiO2 they're actually on. You can get between 40 to 60% FiO2. You have to keep it at least 5 liters per minute so that you will still get CO2 clearance. Of course, it interferes with eating, talking, coughing, and then it can be dependent on the face fit. So people who have very narrow, thin faces, it can actually be going off on the side. People who have much larger faces or have a lot of facial hair, you won't get a very good fit, and then the FiO2 is even lower. Venturi masks, you almost never see anymore, but you might. So I just want to mention them. The cool thing about Venturi masks is you have these like different adapters on the bottom, and you can actually put a different adapter on and then change the FiO2 based on that. It's similar to a different face mask, but you can get a little bit higher FiO2 that's a little bit more reliable. We've really walked away from these because of high flow nasal cannula, which we'll talk about in just a second. And of course, the non-rebreather. So the important thing about the non-rebreather is it has this big bag at the bottom, And that is where there's oxygen, kind of a pool of oxygen in there. That needs to be full for it to actually be working. So you can get 100% FiO2 by this mask. And again, it has the same problem as the other masks do. And there might be a little CO2 that is still rebreathed that doesn't come out. But if we're just using a mask, this is the best way to try to get 100% oxygen. All right, high flow nasal cannula. This is actually something that has only been present in regular practice, maybe about 10 years. There were devices around for much longer than that, but they've really taken off with marketing. So you'll see a lot of high flow nasal cannula used. It is typically humidified, whereas regular nasal cannula is only sometimes humidified because the flow is so rapid. I mean, think about a giant industrial fan blowing non-humidified air into your nose, right? Your mucous membranes are going to dry out super quickly. They're going to get irritated. It's going to be uncomfortable. So these are usually humidified. You can deliver a huge amount of flow. And the great thing about the amount of flow you can give is it can also improve ventilation. So you can get better airflow and actually have more CO2 removal because of the flow. It can improve the work of breathing. People can feel much more comfortable on it, and people can continue to talk, eat, cough, things like that. Unfortunately, due to the amount of oxygen that's needed, you know, most people don't have that type of oxygen compressor at home, so it's not ideal for home use yet. And some people are concerned that maybe if you put high flow nasal cannula in, you could miss the opportunity for when they need to progress to intubation. So there are a couple of articles. So 2015, 2016 is really when this became hot stuff. And so if you wanted to look at these articles, there have been people who've talked about extubating even with higher FiO2 and then going to high flow nasal cannula, and that can decrease reintubation rates. So there's some data that this device is helpful. All right, so case number 2, what do you see on the chest x-ray? Hyperinflation, yes. Yep. So big lungs, right? So you get a little history. They have a 40-pack year smoking history, and pulmonary function tests a year ago demonstrate some obstructive lung disease. The patient gets a nebulizer, corticosteroids, and they become more somnolent, but they're still protecting their airway. So what's the next step? What would you do? Check a blood gas, yeah. So they're currently on 5 liters nasal cannula, and this is their blood gas. So now what do you do? Non-invasive. A manual ICU team, you are on it, right? You've probably done this even today. So it's where we talk about non-invasive positive pressure ventilation. And really, we're going to talk about BiPAP. It's extraordinarily rare that we're using CPAP acutely in the hospital. Really, the only times we're just using CPAP in the hospital is if we have newly diagnosed sleep apnea and we know that they desperately are going to need CPAP, and we need to try to work on getting them an inpatient sleep study, which really is an act of Congress, but that sort of thing. So let's just talk about BiPAP. So bilevel ventilation is accomplished with a tight-fitting mask and a mechanical ventilator, right? So a BiPAP is a mechanical ventilator. You should always think of it as a mechanical ventilator. How many times can I say mechanical ventilator in this discussion? So this is a non-invasive mechanical ventilator, whereas the other vents are invasive mechanical ventilators. They still have a lot of different ways that you can manage them, and you should think about when you're working with the settings, what it is that you want to achieve, and that's how you're going to manipulate the settings. So typically we use BiPAP for both ventilation and oxygenation. Very helpful in COPD exacerbation. Many studies have demonstrated that this is probably the best way to go in COPD exacerbation, as long as people don't have contraindications. Also very helpful for CHF exacerbation, and of course, nocturnal hypoventilation, which all of you are familiar with that, and obesity hypoventilation. Number of contraindications. So if they've had cardiac or respiratory arrest where they have stopped breathing, clearly that is time to think about a different device, invasive mechanical ventilation. If they can't cooperate, protect their airway, or clear secretions, so people who are completely obtunded, you have to think really hard about whether it's appropriate to put a BiPAP on them or not. And I know that many of you have seen people who are pretty drowsy. You know it's a COPD exacerbation. They've been in the hospital once a month for COPD exacerbation, and you'll take the chance of putting a BiPAP on. That is probably okay, so long as you have safeguards about, you know, within an hour, if their mental status is not better, they need to be ventilated or something else. People who don't really know why they're obtunded and you put non-invasive ventilator on them, you really have to be thinking twice about that, particularly because it is easy to get a lot of air in your stomach and then vomit when you're getting intubated because the non-invasive ventilator was unsuccessful. If they have non-respiratory organ failure, especially shock, you should reconsider whether a BiPAP is appropriate. And the reason for that is typically when people are going into severe septic shock, you have to manage multiple different things at once. And frequently you have to use the invasive mechanical ventilator in order to try to blow off CO2 to make up for the metabolic acidosis. And so non-invasive mechanical ventilators are usually not the best tool. If people have facial surgery, trauma, or deformity, sometimes that doesn't work. If they've had a prolonged duration of mechanical, if they are going to have a prolonged duration of mechanical ventilation, like if they had spinal cord injury acutely, that's probably not appropriate. Or if they had a recent esophageal anastomosis. So occasionally we will have patients come to the medical ICU who had an esophagectomy with reanastomosis, and they'll have respiratory failure from aspiration. Absolutely do not put them on non-invasive ventilation, because if you put air into their esophagus, as often occurs when we put non-invasive ventilation on, it will actually rip the anastomosis. And then if people need emergent intubation, obviously that's a contraindication to non-invasive. Oh, and recent transsphenoidal surgery. Yes, absolutely. That is another great contraindication. I'm guessing that must have come up recently. All right. So here it is. This is what a BiPAP mask looks like on a mannequin. It needs to fit tightly around the face. There are different kinds of BiPAP, some that just go over the nose, some that are actually like entire helmets, some that are just forward facial helmets. What we have here at Legacy most commonly are what you see right here. A good general starting place is to actually start 5 of PEEP. So that's 5 of continuous airway pressure, so 5 centimeters water, continuous pressure. And then for ventilation, right, what you're doing is you're adding IPAP, right? So this is just like adding pressure support, right? So you add the IPAP, the inspiratory pressure for the ventilation. So whatever tidal volume you want to get, that's how much IPAP you are adding. So there is a titration to it, and it's based on what minute ventilation you hope to achieve. When people have increased body habitus, you may need more pressure because you have to overcome the external pressure of the chest wall. It's ideal to try to minimize leak around the mask, although sometimes that's very hard without causing pressure sores. So our respiratory care providers are very good about checking for that. And then you need to make certain that you have a plan, that you're going to be checking serial blood gases or mental status or both, depending on the individual patient, to ensure that what you're doing is actually working. All right, so case number 2 continued. This person is placed on BiPAP. with the IPAP of 10, EPAP of 5. Their blood gas is now 732, PCO2 48, PO2 is 120, and their SAT's 95%. The next morning, the patient's looking a lot better, no wheezing on the exam, and they're still on the BiPAP. So now what do you do? So the answer is easier than you think it is. Yeah. Titrate off the BiPAP. Yes. Trail off, right? Eventually, you've got to try it. And the great thing about having a mask on their face is you can just slap the mask back on. So it is really important to ensure that when they are looking good, you're actually trying to take them off of the BiPAP. And usually our respiratory therapists are very good about just doing that without asking you. But if it hasn't happened, you should really talk to the respiratory therapist and say, oh, when are we going to try them off BiPAP? And again, that's going to depend on what the nurse is doing at the bedside and ensuring that there's somebody to watch and make certain that that patient is doing well. And then you closely monitor with either exam and or blood gas. Usually it's exam and mental status. If their mental status is doing okay. I am not somebody who does a ton of blood gases. Great literature about how we make people have way more blood transfusions because we do labs that aren't necessary. And honestly, if her PCO2 went up to 60 and her mental status was fine, are you going to put her back on BiPAP? Probably not, right? So it's important to think about what are the outcomes that you want to see instead of just following labs for no reason. All right, so back to our first case. Again, this person who came in after a drug overdose and aspiration. And so what do you see on the chest X-ray? Bilateral infiltrate diffusely, yeah. Yeah, and that's probably massive vomitus with ARDS associated with it, right? So the things that can cause acute respiratory distress syndrome, most commonly pneumonia or sepsis, other causes of sepsis, aspiration, sometimes trolley, and then long bone fracture, right? So this is somebody who had aspiration and now has had a lot of inflammation related to the aspiration. So your blood gas is 7.28, PCO2 is 60, and your PO2 is 70. So what are you going to do now? Yes, of course you guys are going to intubate, right? Yes. So how do you make the decision to intubate? So there are absolute indications, right? So people have had arrest. Clearly, that's a reason. If they have respiratory acidosis that's refractory to non-invasive positive pressure ventilation, and I'm going to say the caveat to that is refractory acidosis with mental status changes. It is not infrequent that you'll be on the ward and somebody has a blood gas that looks terrible, or you'll be in the emergency department and their blood gas looks terrible. They have BiPAP. Their blood gas doesn't look a lot better, but now they're awake and actually joking with you. That is not the person you intubate, right? So if they have refractory acidosis and their mental status is still altered, then those are the people that you need to subsequently intubate. People have refractory hypoxemia, despite the fact that we've used our other non-invasive measures. If they can't protect their airway, if they have a lot of difficulty with clearing secretions, or there's an obstruction of their airway, or shock associated with respiratory failure. So those are definite indications to intubate. It's a clinical decision. It's not based on the blood gas. And you should always err on the side of patient safety. Always think ahead. If need to intubate is expected in the next day, you should really think about if you're going to intubate now. And one thing for you all that I always want you to think about is that when you're signing out from shift to shift, particularly when you're working in the ICU, is if there's somebody who's been borderline for, you know, any time during the day, I really want you to put your attending on the spot and say, what will happen that will make us intubate this patient? Because I can think about many times where I put you all in a horrible position, right? There are some patients who have known chronic, terrible lung disease, particularly the pulmonary hypertension patients that we see most commonly at Good Sam, who we will put on non-invasive ventilation, and they are usually right on the borderline. In general, if somebody is on non-invasive ventilation and their FiO2 is above 80% and they're still on the borderline, I'm usually moving to intubate those people. However, you know, those of you who've been around, there are some people who, you know, if you intubate them, you're not certain you're going to get them off the mechanical ventilator. And so we drag our feet and we think maybe there are other interventions we can do, maybe a little more diuresis before we cross that line. For your protection and for patient safety, you should always say what needs to happen for me to think I need to call the emergency department, call you, call anesthesiology to proceed to intubation. And that should always be on your sign out list. If anybody is questionable with respect to their airway, always have that as one of the parameters. And honestly, there are times where I'm like, I don't really know when that time's gonna come. They have to look a little worse and you're thinking, wow, they look really terrible now. And it's kind of that gestalt part of it. But always ask, and sometimes that will press us to intubate during the light of day when everybody's present. It always goes better that way. We know from data from multiple centers that emergency intubation is always associated with poorer outcomes than planned intubation. So think about that ahead of time. All right. Okay, so kind of the overview for those of you who like flow charts. So with respiratory failure, you can follow 3 paths. Either secure the airway, supplemental oxygen, treat the underlying condition. If you need to secure the airway, you need to think about, do they need intratracheal intubation or tracheostomy? If no, then non-invasive mechanical ventilation. And if that fails, invasive mechanical ventilation. If they do need intubation, then you go to invasive mechanical ventilation. Super easy schematic here. And then as far as mechanical ventilation goes, there are 3 things that it does for us. It corrects hypoxemia by allowing for increased fractional inspired oxygen, as well as PEEP, so positive pressure, that actually opens the airways and allows them to participate in gas exchange. It enhances ventilation with respiratory rate and tidal volume. And then the other really important thing about mechanical ventilation is that it decreases afterload and preload. Always, always, always decreases afterload and preload, and can decrease metabolic demand, which can help optimize cardiac function. I think about the people who always fool me in breathing trials are people with really, really bad mitral valve disease, because they can look really good on just a little bit of pressure support in PEEP. And then as soon as we take the tube out, they have flash pulmonary edema and we're right back to where we started. So even a little bit of pressure support in PEEP can dramatically improve afterload and preload in certain patients. By enhancing ventilation, we correct respiratory acidosis. We can help people who actually have neuro or muscle dysfunction. Sometimes we'll use hyperventilation in people with acutely elevated intracranial pressure. Again, that's only for acute treatment when it's a bridge to some other treatment. It's never a chronic treatment. And then sometimes we can use mechanical ventilation to meet increased metabolic demand. And then as far as ventilators go, general principles, the main goal is try to avoid trauma from the ventilator. We don't positive pressure ventilate normally, right? We are negative pressure ventilation organisms, which is why maybe the iron lung made a lot more sense. But since we have positive pressure ventilation now, it's really important to avoid the different types of traumas. So barotrauma, volume trauma, atelectatrauma, and hyperoxygenation. really titrate down your oxygen to the least amount of FiO2 that will actually achieve the goals that you have. And the oxygenation goals are going to vary by patient type, so I'm not going to go over that in detail during this lecture, but make certain that you have a goal and that you're staying on top of that. We're going to ventilate with 6 mils per kilo or less in ARDS with a plateau pressure goal of less than 30. You should almost never have a high tidal volume ventilation. Occasionally we'll have high tidal volumes for severe metabolic acidosis or if they have spontaneous breathing trial going on. PEEP titration is to target reducing atelecta trauma. For those of you familiar with driving pressures, that is part of the issue. High CO2 is actually okay and might be helpful. If you remember the Haldane effect, go way back, right? So when you have more CO2 circulating, the oxygen is going to have the hemoglobin is going to have higher affinity for the oxygen, so it can actually help you deliver oxygen to your tissues. So higher PCO2 might be helpful. And then always think about, can you get them off the ventilator when your FiO2 is less than 50 and PEEP is less than 8. A little bit about blood gas interpretation, since I have a few minutes. So the normal convention that we use, so depending on where you go, the PaO2 and PCO2 may be in different places, right? So we tend to do pH, PCO2, and those are usually the two numbers that I care about. PaO2 I rarely am interested in. The bicarb is always calculated, it's not measured, and then saturation. Here's the range of normals, and keep in mind that minute ventilation is equal to the tidal volume times the respiratory rate. So this is something that I frequently go over when you have to work with me in the ICU, so I'm going to do it here. So when you get a blood gas, frequently you have to decide how you're going to adjust the ventilator. And I see people doing a lot of trial and error, which results in a lot more blood gases and a lot of wasted blood. So let's say you currently have a patient on volume AC, and their tidal volume is 500, respiratory rate is 12, the PEEP is 10, and the FiO2 is 50%. So not an uncommon ventilator setting, nothing fancy here. And you've got a blood gas at 7.12, PCO2 is 60, PaO2 is 80. So you have to figure out what you're going to do. And how you remember that is you go back to this relationship between pH and PaCO2. If you have a little ICU card somewhere that has this relationship, that's great. You need to have it down somewhere. However you keep notes, Evernote, something like that. This relationship is extremely important on your ICU rotation. So, and this is for acute changes, right? Chronic changes is about 0.03. So the acute change in pH is about 0.08 for every 10 millimeter mercury difference in PaCO2. So what you do is really easy algebra, right? So what you take is your current PCO2 times the current minute ventilation, and then you solve for your desired PCO2 and desired minute ventilation. So how we go about this is, let's say, so a pH of 7.12 is a little too low. In animal models, when your pH dropped below 7.25, the animals lost sensitivity to exogenous catecholamines. So that meant if you were in shock, the norepi didn't work as well. So we want to get that above 7.25. So to make math easy, we're going to go 7.28, right? So that's an increase by 0.16. If we increase the pH by 0.16, our PCO2 has to decrease by 20, right? Everybody following that? So our goal PCO2 is 40. So what we want to do is we'll plug in these numbers. So 60 times the minute ventilation, which the minute ventilation is in liters, 0.5, so it's 500 mils, 0.5 liters times 12. So 0.5 liters times 12 gives you your minute ventilation. So the minute ventilation is, sorry. So it's 60 times 6 divided by 40, which equals 9, right? So the desired minute ventilation is 9. Let's say that you want to keep your tidal volume the same. So you take 9 equals the tidal volume times the new respiratory rate. New respiratory rate is 18. That's the vent change that you make. So long as you don't have a rapid change in metabolic acidosis, or some shunt open up or some other unforeseen thing going on, this math works. And so this is the approach that you should take if you're going to change anything on your ventilator. All right, so now I was going to have time for questions. Anybody have questions on this? And then I have like board review questions if we've got like 5 more minutes. Okay, while you're thinking of questions, here we go. So, 56-year-old male, something you'll see all the time. Vomits 300 mils of bright red blood 15 minutes prior to you being called to come to the bedside. Past medical history is consistent with alcoholic cirrhosis. He's got a blood pressure of 99/50, heart rate 110, respiratory rate 25, that's 93%. Can respond to painful stimuli only. Heart's regular, lungs are roncorous, he's got ascites, hemoglobin's 8, bilirubin 6.8, AST 154, ALT 54. He's got 2 14-gauge IVs, and crystalloid is being given. What should you do next? I have one answer. Way to go, Emmanuel ICU team. Yes. Yes, you're going to intubate this person, right? And why are you going to intubate them? Well, one, they're vomiting bright red blood. And when you're going to have to do your emergent endoscopy, you want to have the airway protected. 2, the patient's only responding to painful stimuli, so the patient is obtunded. And 3, with that heart rate of 110, it makes you very suspicious that there could be far more bleeding going on than this hemoglobin of 8 predicts. So the absolute right thing is a endotracheal tube. Thanks. All right, so next, 52-year-old comes to the ICU for dyspnea after upper endoscopy for GI bleeding. It's a lot of GI bleeding around here. Temperature is 37.3, blood pressure 150/99, heart rate 110, respiratory rate 28. So that's 90% on 100% non-rebreather. The patient is awake, diaphoretic and anxious, his lungs have crackles and rhonchi, and he has accessory muscle use. Blood gas, 735, 46, 55. What would you do? And it's like the Emmanuel ICU team has been doing this all week. Absolutely. This person is also getting intubated. The answers are not going to be intubate everybody, but this person is also getting intubated, right? And why are we intubating them? So again, heart rate 110, diaphoretic and anxious. And accessory muscle use, right? This person is working really, really hard. And you can see on this chest x-ray that they've got some aspiration going on here. And so there's already been an insult. So they probably aspirated during the endoscopy. They may have continued bleeding. And so intubation is extremely important. And Chris Lopez wants to make certain new second year seniors. For those of you who are moving up in the world, it's extremely important that you know that it is not a failure that you have to intubate somebody in the middle of the night. People evolve in their course of their illness at any time of day, right? And it's terrible when they do it at night. I wish they would do it between 9 to 5 because that would be better for everybody, including them, but they don't. So it's important to know that if a patient is crumping, you are going to have to be the one that makes the decision to act, which I know is hard. And you can always call if you're worried, but I wanted to kind of bring these cases up so that you would know that absolutely you need to be thinking fast. All right, here is a 70-year-old male diagnosed with ALS 6 months prior, admitted with dyspnea, orthopnea, daytime sleepiness. Blood pressure is 128/73, heart rate's 90, respiratory rate's 28. His SAT's 87% on Rumer. He's got right hand atrophy, decreased mobility, fasciculations. His lungs reveal abdominal paradox when he's breathing. He's using his accessory muscles with shallow tachypnea. He's awake, alert, interactive, but he falls asleep easily. Speech is clear. He's got no cranial nerve abnormalities. Blood gas shows pH 7.3, PCO2 76, and a PO2 of 50. So what is the most appropriate treatment in this patient? See, this is where I feel, oh, yeah, yes, Syria, you're correct. So this is somebody who's going to have long-term issues. This is not acute, right? So when you look at the chest x-ray here, he has atelectasis bilaterally, right, which is kind of part of his long-term issue. So at this point, this is somebody you could try on non-invasive ventilation first. Oh yeah, long-term, maybe long-term trach. We might progress to that, and likely will, and Dr. Sherbin would take care of them. But this person, probably first step would be non-invasive mechanical ventilation, and thinking about what parameters you're going to have about what constitutes a failure of non-invasive. So is that going to be mental status? Is that going to be blood gases? What is it that's going to make you think, uh-oh, this person needs an invasive mechanical ventilator? Okay, this is my last one, right? So 34-year-old, hospitalized for acute respiratory failure after heroin overdose. Afebrile, heart rate 74, blood pressure 114 over 77. Respiratory rate 16, his ideal body weight 63. He's currently on volume AC. His tidal volume is 630 mils. Respiratory rate 16, PEEP 8, FiO2 is 50%. You get a blood gas, 733, PCO2 is 46, and PO2 is 76. What should you be doing now with your vent strategy? And I know this is not a vent lecture, but I wanted to give the senior residents something to think about. Okay, Lopez, Emmanuel ICU team. Emmanuel Clinic, yes, awesome. Absolutely, you're going to reduce the tidal volume. And how much, what are you going to reduce the tidal volume to? Right, so this person's on 10 mils per kilo, right? That's just way too much. And so you're probably going to, yeah, at least less than 8, right? So you may reduce even further. Case series at Mayo looked as a before and after study. They put everybody, irrespective of your diagnosis, on ARDSNet, low tidal volume ventilation. After a certain period of time, they did a look back and found that there was far less progression to ARDS when they moved everybody to being on low tidal volume ventilation. So it's probably a good thing for everyone to do. Thank you so much for your time. And I know that Sam has an announcement. So I will stop talking. If you ever have questions, please feel free to reach out to me. You just want to shoot the breeze about respiratory failure, mechanical ventilation, I'm here for you. Thanks.
Thank you so much. Hey, everybody. That was an awesome talk, Dr. LeTourneau. Really appreciate it. I'm going to go ahead and stop recording.